Now we will move on to the next session. For the next session of panel discussion, may I request Dr. Madhavan sir. It will be a panel discussion. Madhavan sir will be moderating the session. It will be on inpatient management of diabetes. So over to sir.
Good morning and thank you, Dr. Gauri. Thanks organizers of the DAISICON. From the realm of fantasy, we are now coming down to earth. We are going to talk about the inpatient management of diabetes, a very important area for practicing diabetologists. We know that almost 40% of admissions in any institution, medical institution, these days they have diabetes. So it is imperative that we know how to manage hyperglycemia in the inpatient setting, because the implications for the patient are very great. We know that there is very gross fluctuations in blood sugar from hypoglycemia to hyperglycemia in the inpatient setup with great implications. It is not a mere physiological response to the stress of hospitalization, but it is a pathological event due to a combination of factors. The surge of contra hormones which oppose the action of insulin, the comorbidities like hypertension, dyslipidemia, atherosclerotic cardiovascular disease, infections, and poor intake of glucose by the muscle, increased gluconeogenesis from the liver because of increased insulin resistance and reduced insulin secretion. This combination results in very high glycemic levels during inpatient stay. And what happens when these fluctuations occur? The stay in the hospital gets extended. The morbidities and mortality, not only during the hospitalization, but even after discharge from the hospital, the mortality and morbidity can increase. And of course, last but not least, the economic burden placed on the healthcare delivery system is going to be high. So it is imperative that we have a protocol for managing hyperglycemia in the inpatient setting. But you will be surprised to know that as of now, there is no definite protocol for management of inpatient glycemia internationally. There are a number of guidelines, but unfortunately there are no protocols. Even this year, the American Diabetic Association, in its clinical practice recommendation, ultimately says that each institution should have their own protocol and stick to it while managing hyperglycemia in the inpatient setting. So what we are going to discuss today is a set of questions and concepts regarding management of hyperglycemia in the inpatient setting. And of course, there are four panelists. Dr. Vetrivel. Dr. Vetrivel is senior consultant in medicine and diabetology from Vellore. He has his own institution. Of course, Dr. Gauri, a rising star in the field of diabetology. He is a physician and diabetologist in the Indian Institute of Technology, Chennai. And we have Dr. Sendil, and of course, we have Dr. Ashok Ranjit is not there. Dr. Ganesh is from Tanjavur. He is again a senior consultant diabetologist. And we have Dr. Sendil Kumar, who is assistant professor of diabetology in Madras Medical College. All very rising stars in the field of diabetology youngsters. So what I am going to do is start with the first question. We know that there are two categories of people with hyperglycemia in the inpatient setting. One is a known diabetic, already on treatment for diabetes, getting admitted in the surgical or medical ward. But also there is a significant percentage of patients who are not diabetics. After admission, they are detected to have hyperglycemia. And I will start with Dr. Vetrivel. When this patient, you find that a patient who is not a known diabetic has hyperglycemia, what will be your approach in managing the hyperglycemia in this cohort of patients? Dr. Vetrivel.
As the moderator has aptly told, the diabetes is associated with, any person admitted with diabetes is associated with the problem of dysglycemia in the form of glycemic variability, hypoglycemia, hyperglycemia. But one has to know the outcome is very adverse and increase morbidity and mortality in case these are mitigated. So at the question First, we have to differentiate whether he is under stress hyperglycemia or real diabetes mellitus. This will settle the issue by taking HbA1c, the random blood glucose. Suppose if it is more than 140, HbA1c is ordered. If not 2 to 3 months, yes, it has not been taken. So HbA1c will settle the issue.
Yeah, one way of looking at is you can do a glycated hemoglobin. If it is very high, we can say that this is a person who probably was not diagnosed before admission, now diagnosed, and we treat him as a non-diabetic. If the A1C is not raised, then again the treatment modality is the same. Dr. Senthil, can you tell me, suppose it is not high, is for the first time being detected, what will be your approach to this patient?
So every patient with stress hyperglycemia should be treated as per the guidelines. The blood sugar level will always to be maintained within the range of, if it is a non-critical patient, we can maintain the range of 100 to 140. If it is a critical patient, we have to maintain the range of 140 to 180 milligram per deciliter.
So the cutoff is, most of the guidelines say that if the blood sugar on 2 consecutive days, it is more than 180, then the hyperglycemia should be treated. And what will be the drug of choice in this case? Whether, let us say that it is a non-critical case in the surgical or medical ward.
Yes, inpatient wise, we always prefer insulin rather than OHAs. So we can try with, if it is a purely a stress hyperglycemia, we can try with short-acting insulin, and then if it is responding within the target, we can maintain with the bolus. If it is not maintaining any 2 LS or more than exceeded 180, we can add on upon the basal also. So we can either try with basal plus or basal bolus will be an option for you.
Yeah, most of the guidelines say that in the hospital setting, it is always basal bolus. So unless there is specific contraindication, we have to choose only basal bolus therapy, 3 times short-acting insulin and 1 long-acting insulin. That is the recommendation by most of the world bodies today. But of course, we have to be careful about hypoglycemia, because hypoglycemia is one of the serious consequences in the inpatient setting. We have to avoid it at any cost. But as Dr. Senthil correctly pointed out, it should be only basal bolus, unless you are very confident that you can use. We'll come to that, a combination of oral drug with insulin. We'll come to the use of oral drug in inpatient later, but it is basal bolus. This is about the non-critical care. What about the critical care, Dr. Ganesh?
In critical care patients who are critically ill, the blood sugars has to be maintained. We need a moderate glycemic control. That is, you keep the glycemic control between 140 to 180. The reason is, if you reduce the blood sugars to much lower levels, the risk of hypoglycemia is more. So this hypoglycemic patients are more, mortality is more in this critical care patient. So always, rather than putting the patient on strict glycemic control, moderate glycemic control of 140 to 180 is sufficient, and it reduces the mortality and reduces the risk of hypoglycemia.
I totally agree with you, but again, we follow the NICE sugar guidelines. So it says that you have to control. Of course, there are a lot of controversies regarding tight glycemic control in the intensive care setting. It was, I remember correctly, it was 2007 that Von Gore, after analyzing the data that is available in the literature, said the cutoff should be 215. But later, the NICE sugar study very clearly showed that 215 is too high, and it should be reduced to, say, 140 to 180 for even in the critical care setting. But again, the recommendations say that in those cases where there is no risk of hypoglycemia, young people, no comorbidities, you can even try 110, provided you can avoid hypoglycemia. But in older people who are at risk of hypoglycemia, who have comorbidities like renal disease, already they are having atherosclerotic cardiovascular disease. We have to be careful because hypoglycemia can have disastrous consequences in these patients. Now, let me ask Dr. Gauri, there is a controversy regarding sliding scale. It has been there for so many years now, not settled unfortunately. I was surprised when I looked at the literature that the concept of sliding scale was popularized by none other than Elliot P. Joslin, whom we call the father of diabetology. In the last century, it was immediately after insulin was discovered. But down the years, a number of studies have looked at, compared sliding scale with basal bolus and come to very different conclusions. So Dr. Gauri, what is your take on the use of sliding scale in the present day management of diabetes in the inpatient setting?
Thank you, sir. So sliding scale is something which we all misinterpret and misdo things. So every hospital will have their own sliding scale, and this sliding scale the staff nurses use as per their discretion. They will see at 7 o'clock in the morning, then they will see one at 11 o'clock, then they will see one at 5 o'clock, and they will just give the insulin dose as per what is given in their protocol. That is something which should be absolutely discouraged. What do we mean by sliding scale is a proper regimen where it is always seen before food and it takes into account the illness of the patient and the amount of carbohydrate whether the patient is consuming or not. So if you are going to see this, sliding scale is the only way how we can control the blood sugar in the inpatient. So it gives a generalized idea about what is the pattern of sugar, then we can add correction dose, basal bolus, all these things. But to know how to control the blood sugar in the inpatient, sliding scale is the most appropriate one, and this has to be always looked into patient illness, amount of food that he has consumed and amount of insulin requirement based on the previous meal blood sugar. If we do that, sliding scale is a big go-go.
Yeah, correct. Though sliding scale is being increasingly condemned that it should not be used, there are certain situations where sliding scale is very useful. But of course, in these days of where you have glucometers and continuous glucose monitoring systems, it may not be necessary to give a sliding scale. But there are areas, places, even in our country where it is not possible to do frequent blood tests or have continuous glucose monitoring. Sliding scale can be very useful, but what you have to understand is that when you use sliding scale, you are treating the patient in a reactive manner. You are treating the blood sugar which exists in the last, say about, suppose you do it once in 2 years, the blood sugar. You are treating the blood sugar which existed in the last 2 hours, not the present blood sugar. So that is one of the reasons why people don't want a sliding scale. You have to be proactive, not to treat the blood sugar which was there in the last 2 hours. So sliding scale can be useful provided you take certain precautions about how you go about using it. Compared to subcutaneous insulin, basal bolus, what about the continuous IV insulin infusion? Because most of the recommendations now say that, at least in the critical care setting, it should always be intravenous continuous infusion. Dr. Sendil.
So for an NPO patient, it will be, if it is a hyperglycemic crisis like DKA or HHS, you can use a variable insulin. For all other patients of NPO or for better glucose control, we continue with the continuous infusion. So variable, if it is a continuous infusion, it can cover the basal, physiological basal insulin coverage. So it will be an ideal for all the inpatient except for the hyperglycemic crisis condition.
Yeah, in the inpatient setting, in the critical care, it should always be intravenous infusion of short-acting insulin, because we are not going to give long-acting insulin in the intensive care setting. For instance, patient with acute MI, I don't think we will be giving them long-acting insulin. It should always be a short-acting insulin, so that in case the patient goes into hypoglycemia, you can always reverse it immediately. If you give long-acting insulin in the inpatient, in the coronary care setting, it may be very difficult to reverse the hypoglycemia if the patient develops hypoglycemia. So most of the world bodies now say that you should use only intravenous infusion of short-acting insulin, bolus insulin, in the intensive care setting. The another area where you always face problem is in the surgical setup. So you give a long-acting insulin at bedtime. Without that, very often it is very difficult to control the fasting hyperglycemia. So most of the time the anesthetist will write in the case sheet, withdraw the long-acting insulin given at bedtime because they are worried about, I think Dr. Pushpa must be facing it in MMC very frequently. I faced it 30, 45 years back in MMC. So they will write no long-acting insulin at bedtime because they are worried about on-the-table hypoglycemia. You withdraw the long-acting insulin at bedtime, the fasting is invariably high. The patient will go to the theatre, the anesthetist will say blood sugars are very high, you will send the patient back. So how will you face this, Dr. Ganesh?
So what are you asking?
The anesthetist insists on stopping the, in a surgical setup, he wants the long-acting insulin to be stopped in the prior night.
In the prior night, we can reduce the dose of basal insulin. Sometimes, as you said, we can get hypo in the early morning in an ill-oral patient. So we can, if you are preparing for the patient and put him on fasting overnight or for 6 hours after the bedtime snack, it is better to reduce the dose of basal insulin by around 20% for better glycemic control and also to prevent hypoglycemia.
Yeah, that is what I used to advise. I always used to say that give 50% of the basal insulin. What we have been giving previously, give at least 50% so that you balance it. Neither the patient goes into very high blood sugar levels or he doesn't go into hypoglycemia, because on the table hypoglycemia is a serious issue. Those days when we didn't have these instant glucose monitoring systems. So now we have instant glucose monitoring systems. We have to assure the anesthetist and the surgeon that we can always check the sugar on the table frequently, and if the patient develops hypoglycemia, we can always take care of it. So I think probably a reduction the previous night, 50% is what I usually do. I don't know what Dr. Pushpa does in MMC. Do you have any comments on that?
And now the duration of fasting is also coming down in surgical patients.
But with the availability of long-acting analogs now, because they do not have a peak, so they usually do not produce hypoglycemia. So on the table, always there, we can reduce the dose, not like those days when we used to give NPH insulin, which invariably had a peak early in the morning and had the patient went into hypoglycemia. So
rather than giving
late at night. Okay, right. There is always a talk about correction doses in patients who are on intravenous infusion of insulin in the surgical and medical setting. Dr. Gauri, can you tell me what are correctional doses and how do you go about it?
Sir, correction doses are, we are giving an ad hoc dose whenever there is a need. Suppose, let us say, the patient is posted with surgery for early morning. Patient reports blood sugar of 260. You write it in the case sheet itself, because otherwise what happens if the blood sugar is fasting is 260, the anesthetist will say like it is a high, we will not take up for surgery. So he will say like it will get postponed, money increases, all these things. So whenever it happens, make a note like in case if the blood sugar goes above, fasting is more than what we want target, we want 180. So a correctional dose of 6 units or 8 units. That is something which we can do in the surgical setup. Medical setup, if we see like correctional doses, the one which we add to the previous meal. Suppose let us say like post lunch, the patient's blood sugar is 220. So how much do we want? We want the blood sugar to be 180 or so. So 4 units we are going to add for the 220 plus 5 units for 50 grams of carbohydrate that the patient is taking. So 9 units we are going to give. So the extra 4 units that we have given for the lunch has to be corrected the next day with breakfast. Does it make sense? So the patient blood sugar is say 180 or 200, let us say 220. Previous lunch the blood sugar is 220. So how much do we want? We want 180 to be there. So he will need 4 units of insulin. For the carbohydrate for the lunch that he is taking, he will need 5 units. Say 4 plus 4 is 9 units. So this 4 units that we give is called as a correction dose, which we have to add to the next day with the breakfast. So that is the correction unit. So these are the 2 things. Apart from that correction insulin, we do in pumps and all, like there is a different thing. So these are the 2 common scenarios where we deploy correction insulin.
Thank you, Dr. Gauri. One area where again there is a lot of controversy, the use of oral hypoglycemic agents in the inpatient setting. So, Dr. Vetrivel, what is your idea?
Usually we don't give oral hypoglycemic agent in the inpatient setup, especially in the critical ill patient, because of the SGLT inhibitors means it produces euglycemic ketoacidosis and dehydration. And if it is metformin, produces lactic acidosis. If it is sulfonylurea, then it is hypoglycemia will be there. As far as the DPP-4 inhibitors, the score has to settle in. So usually we discontinue in the critical setup. Most of the time when the patient is about to be discharged from the non-critically illness ward, we start gradually the safer OHS.
Oh, as he correctly pointed out, in the critical care setting, there is no question of oral agents. Whatever is the blood sugar level, what is the fluctuation, we don't use oral agents at all in the critical care setting. But in the non-critical care setting, there are always situations where sometimes we can use oral agents, especially prior to the admission, the blood sugar had been reasonably under good control. The admission A1C is not very high. Then maybe the oral agents can be given. There are a number of studies in the recent past which have shown that you can use certain oral agents. Metformin is straight away out. Usually you have to withdraw metformin in the inpatient setting. And SGLT2 inhibitors, as Dr. Vetrivel correctly pointed out, usually we do not go use, in fact it has to be withdrawn prior to surgery itself. And of course there are studies now that DPP-4 inhibitors along with basal insulin can be used in the inpatient setting in the non-critical setup, but always with some basal insulin. So there are a number of studies have looked at DPP-4 inhibitors with Lantus, glargine, and have shown that the results are equally good like basal bolus insulin. So in situations where you are not in a position to use basal bolus insulin, probably a combination of SGLT2 DPP-4 inhibitors with Lantus can be used. And another drug which is being now investigated is of course the GLP-1 receptor agonist, but the results are very preliminary. We do not know whether GLP-1 receptor can be used in the inpatient setting, but of course the recommendation today is to withdraw GLP-1 receptor agonist at least in surgical patients at least 2 to 3 weeks before surgery, because we know that the anesthetists will be greatly worried about staying of food in the GI tract and post-operative vomiting and serious aspiration pneumonitis. So the recommendation today is that you should stop well in advance GLP-1 receptor agonists before planned surgeries. But emergency surgeries is a real problem. The world bodies say that the anesthetist should be warned about the possibility of vomiting post-operative period and aspiration pneumonitis. What will be the plan for discharge, Dr. Gauri?
Sir, discharge in the...
after the patient is getting discharged, what will be the plan?
So if the
patient is on intravenous infusion of insulin.
If the patient is on intravenous insulin, we have to see the amount of insulin that has been administered for the past 6 hours. So say if the patient is taking 1 unit per hour, so it will be 6 units. Of this 6 units, like per day if you see, it will be 24 units. Of this 24 units, we have to take only 80%, means 20% you write it off. Of the 80%, 50% has to go as basal insulin and 50% has to go prandial insulin. Does it make clear? So in the 6 hours, how much the patient has taken. So if he is on 1 unit per hour, it is 6 units. So in the past 24 hours, how much he has taken? He has taken 24 units he has taken. 20% we have to write off, means which is about 20% is 5 units. So 20 units it comes. So of the 20 units, 50% has to go basal and 50% as prandial. So 50% as long acting and 3 short acting of 3 to 4. Or if you are doing it in premix, you can calculate the same ratio and give. So this is how we convert intravenous insulin to subcutaneous insulin.
Before stopping the intravenous infusion and starting subcutaneous insulin, what do you do?
So before starting that, we should make sure that the anion gap is addressed, the acidosis has been addressed. So these are the few things that we need to see. The pH is clear and the patient is fit for taking oral, so is no more critically ill. So these are few considerations we have to see. Like
2 hours before you are stopping the IV infusion, we have to start the basal insulin.
Very correct.
Because if you stop the IV infusion, immediately there will be a rebound hyperglycemia. So in order to prevent this, you have to start the basal insulin 2 to 3 hours before stopping the IV infusion. Then we calculate the total subcutaneous dose, as Sir said, according to the insulin infusion rate in the last 6 hours when the glycemic control is good. Based on this, we can calculate the subcutaneous insulin throughout the day and divide it according to bolus and basal. But the point is, we have to start the basal insulin 2 hours before the stopping the IV infusion.
Don't abruptly stop the IV infusion. Give the subcutaneous insulin, continue the IV infusion, and then after wait for 2 hours, assess the glycemic level, and then stop the IV infusion. Otherwise, as Dr. Senthil correctly pointed out, the blood sugars may go up. One area which we in fact faced serious problem is during the COVID pandemic. The use of high doses of steroids, and we know that in the inpatient setting very frequently we use steroids. So you know that when steroids are used, there is going to be a large fluctuations in blood sugar. So Dr. Senthil, what is your take on steroid and hyperglycemia in the inpatient setting?
Yes, we do come across situations where you have to use steroids in diabetic patients. So it depends upon the dose of steroids, duration of action, whether it is administered OD or twice daily. So accordingly we can plan, and mostly we ideally deal with adding insulin, especially to match the, especially when steroid is taken, it will be, blood sugar will be raised more in the afternoon and peak in the evening. So to co-administer along with the steroid, we have to add NPH insulin, intermediate acting, so it matches the exact action, so that the blood sugar level will be properly controlled. If even though adding NPH is not getting controlled, if it is so high, either we can go for IV insulin or we can titrate with basal bolus enrichment.
So the type of steroid we use has a say on the hyperglycemia. So we know that dexamethasone, which is given in the morning for instance, can have hyperglycemic effect till the evening. So you have to concentrate the blood sugar, pre-dinner blood sugar. Whereas prednisolone is a longer acting drug, and sometimes it can have effect for almost 24 hours. Sometimes we give very large doses of prednisolone. So that can have effect on the glycemic level for 24 hours. Then the 24-hour glycemic profile has to be looked at, and so it all depends on which type of steroids is being used in the inpatient setting. That is also very important. Plus, as Dr. Senthil correctly pointed out, we have to repeatedly do the blood sugars, and if necessary, go in for basal bolus therapy.
So there is a role for glycoside also in the steroid management. Sir.
Yeah, one study has shown that glycoside is one drug. I don't know what exactly is the, you have any idea?
Actually, what they have done, this is endorsed by RSSDA 2016 guidelines also. So what they have done, what has been quoted is 20 mg of hydrocortisone is equivalent to 5 milligram of prednisolone is equivalent to 4 milligram of methylprednisolone. So if you are giving it in this dose, 40 mg of glycoside can be given, and up to a maximum of 240 mg of glycoside can be given. So we have to take it as 20 mg of hydrocortisone, 5 milligram of prednisolone, 4 milligram of methylprednisolone. This is 1 unit. So if you are going to give 20 units of prednisolone, it means that it is 4 unit. So 4 into 40 mg of glycoside is 160 milligram of glycoside can be given in this patient. So this is what RSSDA 2016 guidelines say, and it says like how NPH has to be calculated in a simple diagram. You can, it's easily available. You can download and read.
Thank you, Dr. Kauri. That comes brings us to the recommendation by the RSSDA. Dr. Ganesh, can you tell me what is the latest RSSDA recommendation for patients in India?
Regarding use of oral drugs.
Inpatient management, yes.
Inpatient management in steroids.
No, not in steroids, generally.
Inpatient
management of diabetes, hyperglycemia.
Inpatient management of diabetes regarding oral drugs or what you're asking?
Overall recommendations by the...
Overall recommendation, depending upon the whether patient is in a critical care setting or in a it's a post-operative patient, or depending upon whether patient is in the ward or that. In patients in critical care setting, critically ill patients, nil oral patients, it is always better to keep the blood sugars between 140 to 180, because the hypoglycemia and mortality rate will be increased if you aim for tighter control. In wards, we can keep the non-critically ill patients, you can keep the blood sugars between 100 to 180. Sir.
Yeah, in other words, the RSSDA recommendation, in fact, it was only in 2017 that the last RSSA recommendation was prescribed. It almost endorses what the ADA says. So the ADA recommendation is that you keep it between 140 and 180 in the inpatient setting, but unless there is a specific contraindication, you can even be a little more liberal. Older people with comorbidities where you want to avoid hypoglycemia. At the other end of the spectrum, younger patients without comorbidities, no risk of hypoglycemia, you can even try to bring it down to 110. But of course, you have to be careful to avoid hypoglycemia. RSSDA almost endorses. It was 2017. After that, they have not gone into the inpatient management of diabetes. Anything else you want to add? Yes, Dr. Vetrivel, you want to add something you wanted to try? Dr. Sanjay?
Are we using sliding scale routinely now?
Pardon me?
Sliding scale?
Sliding scale, we are not using it, is not recommended. But there are certain, for instance, a rural area where there is no possibility of frequent blood sugar testing, or an institution where the paramedical or nursing care is not that sound. I think maybe
it is helpful for a short time outcome.
Sliding scales means we are treating the blood sugars according to giving a short-acting insulin depending upon the current blood sugar based on a prefixed chart. Based on the scale, we are giving insulin without basal coverage. This can be used temporarily to start with as a transition therapy, sir. Otherwise, for long term, for long stay, this is not recommended because the glycemic fluctuations are more and the in-hospital complications are more with the sliding scale insulin. And sliding scale insulin means we are treating the blood sugars retrospectively, not preventing it. Rather than preventing it, we are chasing the blood sugars, which is not ideal.
Yes, as chairman was aptly telling, it produces a roller coaster effect of hyperglycemia and hypoglycemia.
A higher fluctuations.
And we have to go for a carbohydrate counting.
So to the extent possible, we have to avoid sliding scale, but sometimes situation warrants that sliding scale can be used, but you have to be very careful. Whenever you have sliding scale, you have to always recommend correctional doses of short-acting insulin. So anything else from the floor? Anybody want to share their experience? Senior people are there.
Sir, there are some situation other than this, enteral feeds and total parental nutrition. In these cases, we are following that we are adding direct short-acting insulin in the bag itself. Is it approved nowadays?
Yes, yeah, it's a good thing used. In fact, because of lack of time, I didn't take up that part of it. The total parenteral nutrition and inpatient stay and management of glycemia. What the latest ADA recommendation says is that for every, I remember correctly, I'm subject to correction, for every 15 milligram of carbohydrate you have to give 1 unit of insulin should be added to the parenteral fluid, intravenous fluid. That is an accepted norm these days.
But as per parenteral nutrition guidelines, no medicine should be added in this parenteral nutrition bottles. Separate infusion.
Yes, correct. But the ADA accepts it that you can give 1 unit for every 15 grams of carbohydrate you give parenterally. Yes, Pushpa, you want to add something? Parenteral nutrition, intravenous fluid. What normally we do is that
Separate infusion.
no, when you give a glucose saline or dextrose.
Add with the dextrose because the dextrose which goes, we cannot assess the speed of the solution. So the blood sugars raise very fast. If we give a separate infusion of insulin and a dextrose separately, the dextrose will go at a very high speed, infusion may not match. So we are not doing such frequent monitoring of blood glucose in our government hospitals. So usually we are able to monitor say once in an hour if we have a good
Correct.
support, otherwise once in 2 to 3 hours. So that's why we use dextrose. In the dextrose we add.
Correct. So this we used to do, we started long back, about 40 years back in the Madras Medical College. What I used to do was add 8 units of short-acting insulin for 1 pint of glucose saline. That has about 25 grams of glucose approximately. That is not given in any textbook.
Sir,
There are no
RSSDA
prospect.
clarifies on this. Even I was also thinking the notion that it should be 8 unit. And that is what we think. But RSSDA clearly says in their recommendation, it should be only 3 units, sir.
Okay.
It is given there in RSSDA guidelines. I was just surprised. I calculated that also yesterday night and
5% extra.
5%. They have given the quantity also, sir. 0.15, 0.10 and into 0.15. 2 things they have clarified. So I calculated that for 5% GNS, it should be 3 units that should be added.
But I think it has to be individualized. Individualized.
Dextrose is double.
It will depend on the person's prevailing blood glucose.
So
Oral 16 units, usually 16,
yeah.
1/6.
One area, of course, again, oral. Those days, there was a big fight in MMC when cardiologists, during cardiothoracic surgery, they give very large amounts of oral. They say that during when the heart-lung machine is attached, there is a very large formation of oxidative stress particles. So they said to wash out, we give oral, large amounts of oral. So we started writing that the oral should be covered with short-acting insulin added to the bottle. There was a big fight. They said, why should we add insulin to the oral bottle? Then we went back and looked at the literature. What we saw that lactate is a precursor for gluconeogenesis. So when you give large amounts of oral, there can be very large rise in blood sugar. We convinced them that they give sometimes 12, 14, 16 pints of
16
oral
units,
during open heart surgery. So we said it has to be covered and it is now accepted. It is in the textbooks also. Yes, Doctor, you wanted to add something? So if there are no more questions, I think we have already exhausted the time. As I told you in my initial presentation, unfortunately, in spite of so many decades of discussion, we don't have any clear-cut protocols for managing hyperglycemia in the inpatient setting. In fact, very recently, the American Diabetic Association, in association with the International Diabetic Federation, has started a program called PRIDE, P-R-I-D-E, Planning and Research in the Inpatient Management of Diabetes. And of course, now the AAC, American Association of Clinical Endocrinologists, and various world bodies have joined this program. Probably down the line, in the next few years, we will have some clarity. Thank you very much.